I'll thank you all for coming to Falls Prevention is Everybody's Business bite-sized training this afternoon. It's going to be a whistle-stop tour, so it's going to be quite fast and furious. And I'm going to be asking you to stand up at one point. And so if you could make sure that you've got an available space to stand up with something supportive like a chair in front of you, that would mean that you'll be able to join in with a little bit of the practical test that we're going to do slightly later on. Forgive me if it looks like I'm looking away from you. I'm kind of looking on two screens, and the bigger screen is easier for me to look at, but I'm aware it makes me look like I'm not looking and engaging with you. So my name's Emma Shires, and I'm the clinical lead physio for the PCN therapy service, and we're formerly known as the community therapy team. And just to give a little bit of introduction, we were originally 3 teams that were brought together. So the original 3 teams were the Falls service, the integrated rehab service, and the domiciliary service. And then just pre-COVID, we were brought together to become one larger team, which became known as the community therapy team. And then after COVID, we have been disseminated and integrated into the primary care networks to create a more localized and MDT approach. So working with our MDT colleagues. And within that, we each PCN inherited a long waiting list full of inappropriate and unsafely managed therapy and falls referrals. So that's what's brought about this piece of work. I was trying to get my screen to move on. So the aims of the session today, I'm hoping that you'll come away with a better understanding of what falls prevention means to you and the organisation, to be able to understand your role and opportunity for helping to reduce falls, to know how and when to refer for specialist falls assessment within Surrey Downs Health and Care, and to be able to share your knowledge and interest with your colleagues and line managers and start conversations about how we collaborate in the management of the falling or at risk of falling patient in our care. So just to put some context behind that, the NHS 10-year plan was brought into play in 2019, and they promised £20.5 billion in additional funding. And then with that, they set out key priorities for how this funding would be spent. And then that introduced place-based care in our neighbourhoods. And we're now delivering care closer to home, working more proactively than ever. On top of that, the instruction for community service has been to use at least £4.5 billion of funding to bring together different professionals to coordinate care better. So helping people to live independently at home for longer and developing more rapid community response teams to prevent unnecessary hospital spells and speed up discharges home. So that money is also for upgrading NHS staff to support people living in care homes and improving the recognition of carers and support they receive, making further progress on care for people with dementia and giving more people more say about the care they receive and where they receive it, particularly towards the end of their lives. So setting the context around falls. So falls are the main cause of injury and injury-related disability and death in older people. And that data was from 2016 and 2017, so quite likely to have increased since the last time it was reviewed. And after a fall, an older person has a 50% probability of having their mobility seriously impaired and a 10% chance of dying within a year, which is a really frightening statistic. So looking at our local population, this data is Surrey-wide data, and I thought it would be useful to have a look at what the predictions is looking like for our numbers of population as it's moving forward from 2018 when the original data was captured here on the left-hand side. So we're looking at the bracket of people in the sort of 50 plus category. that blue line on the left-hand side of the 2018 data has been carried over to the 2043 predictions. And you can see where there is incredible growth in the numbers of population, particularly in the 75 to 79 bracket and the 80 to 84 bracket, the 80 to 85 and the 90-year-old. So our population and the services that we will be delivering, the demands are increasing at rapid rates. And we all know that the biggest threat and challenge to the NHS currently is staffing. So we need to address this as a collective together. So within that data, falls are obviously more common in older people, and the prevalence does increase with age. So for Surrey, in 2016, when this data was captured, 1 in 3 people over 65 and over, so around 70,000 people in Surrey fell at least once a year. And then 1 in 2 people, 16,000 of over 80-year-olds fell at least once a year. So, and we're going to be going on to the consequences of falling later on into the presentation. So just to put that context of numbers into the cost in pounds, then the annual cost of a fragility fracture, so someone that's broken a bone as a result of a fall, has been estimated at £4.4 billion a year. And around 20% hip fracture patients enter long-term care in the first year after fracture, so nearly a quarter. About 40 to 60% of falls result in major lacerations, traumatic brain injuries or fractures. And our Surrey data, again, provided by Surrey Heartland's clinical commissioning group, shows that the average cost of a non-elective admission for a fall is £2,466. So that's without breaking any bones. And then the figure goes up for a non-elective admission for fractured neck of femur to £6,166. And this figure does not cover the cost of care or rehabilitation. So it's quite considerable. And if you think about the volume of patients and the increasing ages and complexity of the patients that we're caring for, we know the demands on all of our services are just going to rise. So within care homes, older people are 3 times more likely to fall than those who live in their own home. And the rate of emergency admission to hospital as a result of a fall is almost 4 times higher among care home residents than older people living in their own homes. And that is down to the fact that people are already living with complex frailty once they're going into care homes, and then they're suffering additional deconditioning and loss of independence when living in the care home. So, but being 4 times higher the risk of falls when going into a care home, particularly on admission to a care home, because the environment is unfamiliar to them, the routines are unfamiliar to them. So just a little slide around the physical consequences of a fall. Some of them are obviously very obvious to most of us, but that immobility or a cut or a bruise or a soft tissue injury, fracture or head injury can often lead to a lifetime change in function. So deconditioning happens really, really quickly as a result of a fall, particularly if there's pain. And so we need to also consider the psychological consequences of falling. The loss of confidence that happens leads to a reduced amount of physical activity, can lead to anxiety and depression around wanting to be able to go out and not being able to go out. It can be associated then with a further fear of falls and social isolation and withdrawal. So there are some really serious physical and psychological consequences of falling. So looking at the NICE guidance, originally written in 2004, updated in 2013 and about to be updated again in 2025, the NICE guidance states that older people in contact with healthcare professionals should be asked routinely whether they've fallen in the past year and asked about the frequency, the context and the characteristic of the fall or falls. And then older people who present for medical attention because of a fall or report recurrent falls in the past year or demonstrate abnormalities of gait and or balance should be offered a multifactorial risk assessment. This assessment should be performed by a healthcare professional with appropriate skills and experience, normally in the setting of a specialist falls service. And this assessment should be part of an individualised multifactorial intervention. So just to be clear, that Surrey Downs Health and Care does not have a specialist falls service anymore. And this is in part of the reason why we've had to develop this transformation project into creating a falls pathway. So some more nice guidance. So many falls are preventable and avoidable, we know. The multifactorial risk assessment and intervention can reduce the falls risks by 15 to 50%. You know, that's a really positive statistic. Assessment without any intervention will not prevent falls. So no good identifying risks and then doing nothing about it. And reassessment is required following a change in conditions or further falls is essential. And that's in the updated NICE guidance of 2014. So looking at the Surrey Downs Health and Care policy on falls, this policy outlines the duties and responsibilities of all trust staff and the process for training, dissemination of information and raising staff awareness of falls management and prevention. Previously, when we were CSH, falls prevention was a statutory and mandatory training that we all had to attend. But since moving over into Surrey Downs Health and Care, that's dropped off. And so we're looking at the potential to reintroduce falls prevention training across the board, ultimately. So that's quite exciting. So this enables staff to identify risk factors with individual patients and target and implement interventions. And so manage the modifiable risk factors for hospital patients and patients in the community settings, because obviously within our organisation, we do have bed-based rehab wards as well. So why is falls prevention everybody's business? So as we've seen, the cohort of patients is becoming more complex, okay, and the volume of patients is increasing. So in order to do this, we need to have a collaborative approach across multidisciplinary teams, working smarter together to achieve a meaningful intervention and outcome. And all healthcare professionals, as we've seen in the NICE guidelines, do have a duty of care to be able to complete a simple falls risk assessment. And I wanted to draw your attention to consider introducing the Appendix O in called the falls screening tool, which is in the Surrey Downs Health and Care slips, trips and falls policy. So it would be good to review that within your departments and look at whether you're creating EMIS templates that have a very simple falls risk assessment within them. And that will also help to prompt you as to whether or not to make a referral into what's going to be our falls pathway. So have a look at your falls, slips, trips and falls patients policy and have a look at the Appendix O falls screening tool. And teams should be able to give simple advice on falls prevention and know where to signpost for that more specialist support. So you will be clear by the end of the presentation around when and how to make a referral. So why do so many people over 65 experience falls? You might think that's quite obvious, and a lot of them are obvious. I did want to go out to the audience to see how many reasons we could come up with why people might fall over. However, because we've got limited time, I'm just going to move on to the next slide and just show those to you. Just a brief few reasons why people might fall over. There are probably in excess of over 400 reasons why somebody might fall. But what we know about falls is that they're often multifactorial. And that just means that there are a number of contributing risk factors associated with why somebody might fall. And our job within healthcare is to try and unpick and identify what some of those risk factors might be, because we can do things about those risk factors in the main. So Looking at risk factors, we have intrinsic risk factors, so those things that are going on internally within us, so usually around medical-based concerns. And so on that list, you can see osteoporosis, frailty, previous falls. We've already heard that having a fall will already predispose you to having more falls. Poor mobility and gait, balance disorders, cognitive impairment, polypharmacy, the use of psychoactive drugs. The list is actually endless, but there wasn't enough room on this slide, on the spreadsheet for that. And then looking at extrinsic risk factors, so things that are external, and these are often the quick fixes, so the things that we can be really proactive about. So thinking about footwear, poor lighting, environmental hazards or trip hazards, a lack of equipment, a lack of care and support, external events like wind, for example. There was a lady who fell over in Dorking because of an earthquake. I was asked to go and see, and now that was an extrinsic risk factor I really couldn't do very much about. Slippery conditions, reduced physical activity. So we'll be diving a bit deeper into some of these risk factors and what we as a collective might be able to do about those. So, as I've said, modifiable risk factors are often quick wins, and they often don't have any or additional cost. So our duty is to act now on those modifiable risk factors and get people out of their hospital socks. You'll see why. So I have done a little review, because these hospital socks are a huge bugbear of mine, and I've done a little review of the research out there and to see whether I could demonstrate, do hospital socks prevent falls? And the answer is they don't. They're used in many hospitals as a falls prevention strategy with no evidence whatsoever behind why. So somebody's just done a real good sales number on us. We've all just taken it that there's evidence and there isn't. And a rapid review of literature found that the studies conducted in hospitals, there was either no impact on falls or falls increased. This is the same for people who continue to wear them at home. You'll see later in my presentation an example of this. So eyesight is a huge challenge to people's mobility and ability to balance as we get older, and changes to vision are really common in older people. So there are a number of conditions of the eye that can affect visual field, depth perception, and I've just put some examples on the bottom there that what, for example, having macular degeneration or glaucoma looks like. You can have a big black hole in the centre of your visual field. If you imagine that you're trying to navigate going up and down a step between your front room and your kitchen, it's really easy to misjudge the depth of that step. So thinking about ensuring people have had their eyesight checked in the last 2 years and that they're wearing their corrective glasses when they should be. A lot of the time people get new glasses and they don't get on with them, so they just go back to wearing the old ones when actually they should be going back to the optician to say, I'm not getting on with these. So double vision is something that's really commonly experienced also as our eyes deteriorate and degenerate in the same way that the rest of us are. So polypharmacy is a huge modifiable risk factor, and within our frailty teams we are really excellent at ensuring medication reviews take place. So if you're on 4 or more prescription medications, it can cause 1.5 to 2 times higher possibility of recurrent falls. Okay. Particularly older adults who use antidepressants, sedatives, hypnotics and anti-epileptics are more likely to fall. So the risk of falling repeatedly after taking sedatives or hypnotics was 1.4 to 4.2 times higher than for older adults not taking these medications. We also need to consider the potential for adverse drug reactions, and that's a response to a medicinal product which is noxious and unintended. So we've prescribed something to make something better, and actually it's had a direct relationship between either the body itself or within the other drugs that the person is already taking, the cocktail of drugs that that person is already taking. So, and we know that the health and financial implications of adverse drug reactions are account for about 6 to 7% of hospital admissions in the UK per annum. And I just wanted to show you might not be able to see this, so we will send this out, is a really, really helpful document around medications, what they do and what their potential side effects are. So I often take this with me into a patient and I'll have a little look and see, okay, so what's the potential side effect of amlodipine? That's a really common drug given to people with blood pressure problems. So the effect on the falls risk is that as a side effect, they can cause hypotension and postural hypotension. So a problem with blood pressure dropping. If I look in citalopram, that's a commonly used antidepressant, and SSRI. The effect on falls risk, orthostatic hypotension, so a drop in blood pressure, and may impair the sleep quality. And when people aren't sleeping well, they're more likely to fall over. So having a look at people's medication and requesting medication review, either via the GP, pharmacist, or community medical team is really, really important because it's a huge modifiable risk factor. So thinking about bone health also, if we're falling, if we've got vulnerable bone health and bone density issues, 1 in 2 women and 1 in 5 men over the age of 60 will break a bone, have low bone strength, mainly caused by osteoporosis, if they're not on treatment for bone density. And most care home residents should be taking daily supplement of vitamin D, but they're commonly not. And it was prescribed across the board free of charge during COVID because people were not able to go outside. But that free of charge prescription has stopped now. So there will be a large number of care home residents that aren't actually taking the correct bone health medication. So that NICE guidance was from 2022. So looking at osteoporosis, over 3 million individuals live with osteoporosis in the UK. That's the diagnosed ones. So those living with osteoporosis we know are at greater risk of fragility fractures, so breaking their bones. And annually, hip fractures account for 1.8 million hospital bed stays and £1.1 billion in hospital costs. Fragility fractures are commonly found in the spine, wrists and hips. And if you think about the impact on someone's functional ability, if they are experiencing a fracture, they will maybe have gone from being fully independent to fully dependent on 24-hour care, potentially. So in women, the risk of osteoporosis increases postmenopausally due to the decreased estrogen levels. And there are individual risk factors for osteoporosis. So we can screen for somebody's risk in relation to their bone health. And that's a tool that's called the FRAX tool. I'm not going to go into that in this training, but it just requires a number of details to be inputted, like height, weight, and ticking a few other risk factors, and then it will give you a score, and that will indicate to you whether or not you need to refer back to the GP for further investigation into bone health. Frailty is what we're describing and using as a measure. So I just wanted to draw your attention to the clinical frailty scale by Rockwood. So frailty is described as the group of older people who are at highest risk of adverse outcomes such as falls, disability, admission to hospital, or the need for long-term care. They're described as having less reserve, an ability to react and respond and recover from some form of insult, whether that's a fall, infection, or hospital admission. We are within our templates grading people using this Rockwood frailty scale and ensuring that we're referring into a frailty MDT for anyone that is a frailty score of 5 and over. So we're being more proactive around monitoring and picking up frailty, which is really exciting. Also within clinical templates, the coding across the templates is now aligning. So for example, if I've coded that Joe Bloggs is a Rockwood 6, that should pull through into the community matron template or the district nursing template, and you'll see that I've already graded that individual as a 6 on the Rockwood. And that then helps to identify if we were coming in at a later date whether or not that individual's changed and over what time period that individual may have changed. It's not usual that people improve on the frailty scale. However, if somebody's broken a bone and they were really fit and well prior to, it is possible to make improvements once the recovery has taken place after the fracture. So, other modifiable risk factors are the environment. So don't be afraid to discuss clutter. The number of houses that we go into that are absolutely full to the brim with clutter, to the point where there is absolutely no room to put in equipment that we can help them. So you can't use a walking frame or a walking aid if there's no space on the floor to use it, or there's no gully to walk through safely. So do feel confident about giving education around trip hazards and how people can avoid doing things that are going to result in them tripping over. Prompt them to use a light at night, especially if they're getting up frequently to use a commode or go to the toilet, or suggest using a commode if needing to get up frequently through the night. Discuss footwear and bin the socks. So wherever possible, please try and encourage people to wear a supportive either slipper or soft shoe or trainer. That's a lot better than them thinking I'm wearing the hospital socks because they stop me from falling over. And in fact, the reason that they are more hazardous is that with the extra use, your foot can actually slide within the sock. So the sock, because of its non-slip bottom, if it has remained non-slip, because they don't once they've got fluff on them, the actual placement of the foot, if the sock doesn't move, the foot will move within the sock. So they are a hazard. And encourage them to use the aids that have been provided for them by previous interventions. So here I'm going to give you a warning, okay? I'm sorry if I'm going quickly, but I know that time is really limited. So if you don't like feet, you need to turn away now or look through your fingers, okay? Just going to give you a moment to do that. So I'm going to give you a clinical example. This is a patient that I actually went to see, but I'm using the example of a district nurse going in to dress wounds for a patient that sustained a skin tear following fall. And as per the NICE guidelines and Surrey Downs Health and Care Policy, she has a conversation during the initial visit with that patient, which we'll go on to. So I don't know how well you can see this at your end, but this is a patient within our care that I assessed literally only a couple of months ago. So this lady had been treated in our acute hospital for a protracted period of time, and it appears nobody's taken her socks off. She's also been looked after by the reablement service at home on discharge, and it appears nobody's taken her socks off. And if they have taken her socks off, they've not done anything about the concern of these horrendous nails. That you can see in the background, she was wearing her socks because they stopped her from falling over, and she was very proud of that fact. And she was also very reluctant for me to take them off, but I needed to be firm because I had some concerns around why she was wanting to wear them and not disclose to me why she didn't want to take them off. So don't be afraid to have that conversation when you are in with your patient, you know, and you're seeing them for whatever it was, whether it's a skin tear, whether it's for leg dressings, whether it's whatever it is within your service that you might be seeing them. If they disclose to you that they've had a fall, or it's obvious because they've got bruising in places that they didn't have bruising or shouldn't have bruising, it's okay for you to have that make every contact count conversation. You know, what happened when you fell over? Were you having any symptoms before this happened? Were you conscious throughout the fall? Had anything changed leading up to the fall? For example, did you have infection, constipation, reduced appetite, reduced hydration, a change in medication? And have you fallen more than once in the last year? Put it to them. Why do you think you fall? And what maybe have you done to avoid it happening again? We know that a large proportion of falls are preventable and avoidable. So this question is really relevant. What have you done? They need to take responsibility around avoiding it happening again. And have you reported it to the GP? Because over half of falls aren't actually reported. So it's really important that we encourage people to report it or offer to make referrals in regards to falls for them. And really importantly, do you wear an alarm? So if they're living alone and they've got no method of contacting somebody, the key is to reduce the potential for a long lie on the floor, because this can actually be life-changing and life-threatening. So your visit is an opportunity to share your knowledge and to encourage them actively to be a little more active within their days. Okay, and it's also an opportunity to explore the wider resources and explain the wider resources that we have available to improve not only their falls risk factors but health inequalities as well. So thinking about using your proactive care teams to help support people with accessing things, meaningful activities in their lives again. So it's your opportunity basically to give falls prevention advice. So the good news is most of you are having this type of conversation with your patients already, and you're documenting it, and templates are now aligning so that we're all joining up in our visibility and communication across services and across teams. And many of you are already making onward referrals to the appropriate organisations and teams to support that wider within place. So, for example, charities, for example, like Age Concern and Active Surrey and Action for Carers, who provide ongoing training and support for carers. And the other element to the good news is that deconditioning can be reversed with just a little support and encouragement. And you'll see later on in the presentation that it doesn't need a physiotherapist to be able to have conversations around moving more and increasing activity levels. So I just wanted to show you this slide quickly around what happens when we're deconditioning. So on the left hand side we've got a cross section of a thigh. They're all cross section of thighs. I know they look like a steak, but actually the cross section of the thigh, the red bit is the muscle and the cream outside is the level of fat, and down the center is the bone. So looking at how that MRI cross section changes with a 70-year-old sedentary man, we can see that the level of muscle tissue has atrophied, and we can see that the amount of fat level has increased, and the bone density within the center of that femur has also changed. And that is compared in contrast with a 70-year-old person that is remaining active and is still a triathlete, which I know is not realistic within our population in the majority. However, it's just to give that visual example that inactivity will result in decreased muscle strength at a rate of 1 to 3% per day, with notable strength loss occurring after about 2.5 to 3 weeks. And unfortunately, the majority of that muscle loss happens in the big, dominant, powerful weight-bearing muscles. So the thigh muscles, which is the main muscle with the glutes that contributes to making somebody able to get up and stand and walk and transfer independently. So if somebody's had a hospital stay of about 2 weeks and they've not been got out of bed because nobody's had time to do it, they will have lost a significant percentage of those muscles and core strength. So some of the main reasons for falling then, just to go over a few umbrellas, if you like: deconditioning, so loss of activity, reduced activity levels. COVID obviously created a huge amount of deconditioning within our older population, as a lot of them were shielding, not able to go out, not able to complete their regular routines and activities like getting on and off buses, going to have social interaction, going out to exercise classes if they were doing that. So we're still living with the legacy of COVID impacting on our older population. One of the biggest contributors to falling is postural hypotension, so drops in blood pressure when people initially stand up. And this can, in the majority, be not symptomatic, so they might not be aware at all, because there's no dizziness of the blood pressure dropping. And as we saw within the medications that a large proportion of medications that people are put on will have the risk of postural hypotension as a side effect. Dehydration will also impact on the risk of postural hypotension because blood pressure medication works on blood volume. So if they're dehydrated, there's less blood volume, and that can bring on and create a postural hypotension. So we do need to be reviewing people's lying standing blood pressures. Poor decision making and lack of insight. So lots of people live with that Peter Pan. They still think that they can do cutting trees down, painting fences, DIY, making poor decisions around their physical function, choosing not to use their walking aids that have been prescribed for them. There's a lack of equipment that's needed to optimize their independence, potentially, visual and hearing impairments we've talked about, and loss of balance. So I have just gone into postural hypotension, but just to state at the bottom there, people experiencing postural hypotension are 2.5 times more likely to have recurrent falls compared to those without, and a large proportion, ranging from 28% in females and up to 81% of older adults screened using continuous blood pressure monitoring, were found to have a problem with postural hypotension. So if you're not familiar with taking blood pressure, that's something you might well take back as a positive outcome of this training today, to talk to your line manager around, should we, within our service, is it appropriate for us to be completing lying standing blood pressures? Okay. So there are lots of causes of balance loss associated with aging, and we don't have time to go in depth into any of these, but if you look at the list on the left, that's just a snapshot of reasons why we may have reduced balance. But the balance system ages with us, just like our joints are aging, just like our brain is aging, our skin is aging, unfortunately. So a combination of factors coinciding with multi-pharmacy, nutrition, hydration, vision, depth perception, lifestyle and environmental factors, pain, weakness, posture changes that happen as we get older, changing our centre of gravity, and slowed processing. So the ability to react and take a step when you have lost your balance is slowed down. And a research article by the British Journal of Sports Medicine basically studied 1,700 middle-aged people over the course of 10 years, and the outcome of their research was that a inability to balance, and this was to stand on one leg for 10 seconds, is associated with an almost twofold increased risk of death, which is really quite a scary statistic there. So quick check of balance. Okay, if you're in a safe place and it's appropriate to do so, and you've got something to hold on to, I'm going to ask you very quickly to stand up. I can't see any of you, and please do not make me complete a Datex at the end of this because somebody's fallen over. So you do this only if you have got no concerns around your balance. But if you stand up and just put your feet together, okay, you'll see that that probably doesn't really change or impact on your feeling or sensation of being balanced. But if you put your hands near your chair, just in case, if you now close your eyes with your feet together, you might perceive that that's just a little bit more wobbly. Okay, so we've given you a bit of a visual impairment there and a little bit of peripheral neuropathy. So I'm going to get you to open your eyes, okay, and now try balancing on one leg, but hold on to the back of the chair. Okay, once you're steady and holding on to the back of the chair, see if you can take one hand off, and if safe to do so, take the other hand off. Okay, let's see how your balance is there. Okay, now I'm going to get you to put your feet down on the floor again and go to the other leg, because you would have chosen the dominant leg, the leg you were more confident in. Stand on the other leg now and take your hands off and see what impact that's had on your balance. Okay, and then if you feel safe to do so, keep your hands closed. Just see if you can close your eyes just for a second. Okay, and open your eyes. So here, that's just to give you a little opportunity to stand up and take a break from sitting down, but also to understand what it feels like to potentially have an impairment of your balance and how unsteady that can make you feel. So you can have a sit down again. We're looking at the Chief Medical Officer guidelines for physical activity now, just because one of the takeaways I want to be from this exercise today is to raise confidence within our teams, within our services, to be able to have conversations around increasing physical activity within people's daily routines. So the CMO guidelines for physical activity are unrealistic for our population, where it says to do at least 150 minutes of moderate intensity activity a week, or 75 minutes of vigorous intensity activity if you're already active, or a combination of both. But what I've highlighted here is the message here is to aim to be physically active every day, even if it's just light activity. So those people who have developed a fear of falling, we need to be promoting them to be doing some form of at least seated exercise or seated movement opportunity in order to prevent that rapid deterioration and sarcopenia, reduction of muscle bulk and strength. So it's recommended to do activities that improve strength and balance and flexibility on at least 2 days a week. Again, our population may not be able to consider that, but the key message on the lower part of the slide is we need to educate people around reducing the time spent sitting or lying down and breaking up long periods of not moving with some form of activity. So the slide here has demonstrated just very quickly that if physical activity were a drug, we'd refer to it as a miracle cure due to the great many illnesses it can prevent and help treat. So that's from the Chief Medical Officer again in 2019. So just on the top right hand here, we can see that regular physical activity reduces the risk of all-cause mortality by 30%. So the more we move, the longer we'll live. Okay, and then pertinent to falls and fractures, that regular physical activity reduces the risk of hip fractures by up to 68%. So building confidence around regular movement opportunities is hopefully one of the takeaways that you'll have from today, because it's a modifiable risk factor in preventing falls. We know that physical inactivity leads to all of the below: reduced strength, balance, flexibility, cardiovascular fitness, coordination, confidence and independence. And we get into what we call the cycle of deterioration. So once a fall has taken place, there's usually a loss of confidence and a loss and reduced activity, whether that's because of the loss of confidence or because of an injury. That then feeds into that loss of strength, and that feeds into the loss of mobility, and then that predisposes them to an increased risk of falling again. So that cycle of inactivity is where we need to intervene and be comfortable having conversations about intervening. Okay, so that intervention, I can't remember if I was going to talk about it here or now, but I will just go back to talk about those interventions and those conversations. So I'll give an example. So if somebody's getting up fairly regularly to use the toilet, it's great because it's an opportunity to get up off their chair and relieve pressure areas. It's also going to use 200 muscles. You'll see in a minute that to stand up we require 200 muscles to 100 muscles, I think it is, sorry. And also an opportunity that once they may have already been to the bathroom, they then could plug in to some form of physical activity. So whether that's doing a lap round the lounge before they go back and sit down, whether that's they've gone to the toilet downstairs, but actually now they've been to the bathroom and there's no rush, they could go up and down the stairs as a physical activity, or they could sit it back in their chair and do stand up and sit down 3 times in a row. So just encouraging people to add a little bit of additional movement into their daily routines will make a significant difference, as you'll see in a moment. So I wanted to introduce you to the new Surrey Downs Falls Prevention Pack that we've worked really hard to develop and upgrade and improve. And one of the key things that we've done within that is this nice new falls checklist. So making sure that when we're going in to do an initial patient assessment, that we're drawing attention to, let's have a look at this checklist and let's sign off on all the things that you think you might be able to do as an individual to help reduce your risk of falling. So do familiarise yourself with what's in that falls prevention pack, because actually a lot of work has gone into it and there is a lot of information in there. So for example, for our more mobile patients, we've got from Active Surrey a exercise booklet called Able Like Mabel. And within that, there's lots of lovely exercise and description of exercise in there. There's also the Get Up and Go booklet that's been completed by Saga and the physio standards. And within there, there's also some standing and strength and balance exercise. But also within there, there is lots of information about fall proofing your home, how to reduce falls, what you can do to be proactive in relation to managing your falls risks factors. So spend a little time having a look through those packs because they are really valuable information. They've also got lots of useful contacts on there for accessing other resources, so you can signpost people to those. They'll have a think about those people who are still able to get out of their property as well, because there are lots of local classes going on for the 65 and over population to promote strength and balance. So every movement counts. This little graph here looks at the bottom axis is how many minutes of physical activity per week are taking place, and then the vertical axis is around the health benefits. So you'll see that those people who are moving less than 100 minutes per week are at the area of highest impact if they actually start to move a little bit more. They get the greatest health benefits. So, and they only have to do a little bit more activity to actually achieve that benefit. So just by incorporating those regular little movement breaks or movement opportunities within a day, they are going to make significant gains. And they are usually the most significant in the more frail. The more frail, the more you can make them move, the better it is. And in fact, just as a byproduct of that, this is reinforced by another new study published in 23, querying the 10,000 steps a day. So the outcome of that study was, in fact, every extra 1,000 steps beyond 4,000 steps, not 10,000, reduced the risk of dying early by 15%. And that's up to 20,000 steps a day. So walking does benefit everyone. So have a think about how that you might be incorporating more regular physical activity into your daily lives and your loved ones' daily lives. This isn't just necessarily about the patients that we're caring for. It's also about our loved ones too. As I've said earlier, we need to minimise sedentary time. It's key. Sedentary time or sitting is the new smoking, okay? We use 100 muscles to stand up. So every time somebody stands up, they're making their circulation work. They're helping to reduce lower limb edema. They're helping to take pressure area risk away because they're taking the pressure off those buttock areas. And sitting is a separate health risk, okay? And sitting for just 20 minutes or more, which I know you have been sitting, starts to affect your organs, your blood flow, muscles, bones, gut, and mental sharpness. So just by asking somebody to stand up, for example, when the adverts go on, why don't you just stand up? If it's safe to do so, just stand up while the advert break is on and then sit back down again. You know, you don't need to be a physio to prescribe activity and movement. So we just alluded to this. The positives are moving more. We're reducing the risk of pressure areas. We're reducing lower limb edema because we're making those muscles work and pump that fluid back up to the kidneys and heart. We're improving or maintaining muscle strength, and we're maximising independence. We get feel-good endorphins, which improve mental health, and we improve our cardiovascular health and have an impact on weight management as well. So for the majority of people, physical activity is safe, even for those living with symptoms from multiple medical conditions, and any amount of movement will be beneficial. And there's usually no need to gain permission from a health professional or a doctor, provided that the patient is advised to start gradually and do things small. There are loads of resources that we are going to share with you where you can access things like seated exercise. I'm a big promoter of helping people to get onto YouTube, to follow YouTube seated exercise for older people, so they can just join in and do what they can. They don't have to stand up if that's not within their ability. So we have got lots and lots of information that we'll share latterly around how you can access information around movement and activity. So just going on to latterly, what's the Surrey Downs Health and Care Falls pathway, and also to introduce you to the fact that the Falls pathway has become a self-referral mandate. So it's a direct mandate from the government that we have to offer self-referral for falls. That came into place in 2023. In some primary care networks, we're close to being able to deliver that, or indeed have started delivering that, but that's the next shift. Having created our falls pathways within our primary care networks, we are now having to open up to self-referral. And that's due to the continuing shift towards community-based healthcare, including enabling more people to benefit from proactive and personalised care, strengthening timely access to community services, and streamlining direct access and set up local pathways for direct referral. So that's coming and will be embedded into the primary care network falls pathway. So how that pathway happens is you will make a referral into SPA for falls, and on that referral, the more information that you can provide, the better the outcome for the patient is going to be. So we want to know what you've done proactively in regards to trying to support that patient and reducing their falls risk factors. So please say that you've discussed footwear and you've encouraged them to remove trip hazards, and that you've potentially done a lying standing blood pressure, or you've referred them back to their GP to have a medication review. Let us know all the things that you've been proactive about, so that when we triage that referral, it's easier for the triage, whether it's the duty clinician or it's the therapist, to be able to say, where is the best place for this specific referral for this individual patient to sit for an initial assessment? Because it might be under UCR. This might be an urgent scenario. You know, they've fallen 3 times this morning and they're at risk of going into hospital. It might be proactive care. So they are only a Rockwood frailty 5 and they're still managing to go out a little bit, but they're still falling over. Or it might be that there's a need for equipment as the priority, and that needs to go to the therapy component of the MDT initially. So the more information that you can give on that referral, the easier it is for that triage to be processed and then aligned to the best person to complete that initial assessment. Once they're within the system, then the MDT will work as a collective and quite often under the frailty umbrella. So these patients will be brought to the frailty consultant meeting and discussed, and that proactive approach will be embedded within that multifactorial intervention that we're doing. So I'm aware that I'm at 4:10 and I only had till 4:15, so that wasn't too bad. So just to go back and review the aims of the session. So I was hoping that from today's session, you would have a better understanding of what falls prevention means to you and the organisation as a whole, and why we're having to deliver on this at pace. You will understand your role and the opportunity for helping to reduce falls. Oopsie, didn't mean to press the button there. You'll know how and when to refer for specialist falls assessment within Surrey Downs Health and Care. and you'll come away with hopefully inspired to share your knowledge and interest with your colleagues and line managers and start conversations about how we collaborate in the management of the falling or at risk of falling patient within our care. So my key takeaways hopefully for you are falls prevention really is everybody's business, okay? And don't be afraid to encourage people to build more movement opportunities into their daily routines in whatever way that they can, whatever's safe for them. If someone has fallen in the last year, refer proactively to SPA. Give us all the information that you can on that referral, and then we'll take it from there under the PCN falls pathway. And don't be afraid to have a make every contact count type of conversation. It is our duty of care to ensure that we are delivering on education and preventative information to our patients. And that is it from me. Any questions? I'm going to stop sharing. It's all gone quiet. Hopefully you're all overwhelmed with loads of information.
I'm quite lucky, Emma. I can just next door if I need any info or questions.
Excellent. So Jane, is there an opportunity to give feedback? I didn't ask you that before we went live, because this is the first time this presentation.
Yeah, we'll send something out, Emma.
Okay, that any feedback that you can give would be really, really helpful, because
I'm going to stop recording so people can talk. I've got to hop into another meeting, Emma, but it was really, really interesting. Thank you so much.
You're welcome.
Just so you know that Molesey Hospital